Welcome back, everyone. We continue our discussion on the management of diabetes in pregnancy, a clinical update. Today's topic is preconception care and counseling. Let's discuss preconception counseling. All women of childbearing age with diabetes should be counseled about the importance of tight glycemic control prior to conception. Observational studies show an increased risk of diabetic embryopathy, especially anencephaly, microcephaly, genital heart disease, and caudal regression, directly proportional to elevations in A1C during the first 10 weeks of pregnancy. Spontaneous abortion is also increased in the setting of uncontrolled diabetes. Although observational studies are confounded by the association between elevated preconceptional A1C and other poor self-care behavior, the quantity and consistency of data are convincing and support the recommendation to optimize glycemic control prior to conception. With A1C of less than 6.5% or 48 millimoles per mole associated with the lowest risk of congenital anomalies. Next, there are opportunities to educate all women and adolescents of reproductive age with diabetes about the risk of unplanned pregnancies and improve maternal and fetal outcomes with pregnancy planning. Effective preconception counseling could avert substantial health and associated cost burdens in the offspring. Family planning should be discussed, and effective contraception should be prescribed and used until a woman is prepared and ready to become pregnant. To minimize the occurrence of complications beginning at the onset of puberty or at diagnosis, all girls and women with diabetes of childbearing potential should receive education about 1. The risk of malformations associated with unplanned pregnancy and poor metabolic control, and 2. The use of effective contraception at all times when preventing a pregnancy. Preconception counseling using developmentally appropriate educational tools enables adolescent girls to make well-informed decisions. Preconception counseling resources tailored for adolescents are available at no cost to the American Diabetes Association. Let's proceed to preconception care. Preconception visits should include rubella, syphilis, hepatitis B virus, and HIV testing, as well as a pap test, cervical cultures, blood typing, prescription of prenatal vitamins with at least 400 microgram folic acid, and smoking cessation counseling if indicated. Diabetes-specific testing should include A1C, thyroid-stimulating hormone, creatinine, and urinary albumin to creatinine ratio. Review of the medication list for potentially teratogenic drugs, for example, ACE inhibitors, angiotensin receptor blockers, and statins, and referral for a comprehensive eye exam. Women with pre-existing diabetic retinopathy will need close monitoring during pregnancy to ensure that retinopathy does not progress. Preconception counseling should include an explanation of the risk to the mother and fetus related to pregnancy and the ways to reduce risk, and include glycemic goal setting, lifestyle management, and medical nutrition therapy. Specific risks of uncontrolled diabetes include fetal anomalies, preeclampsia, macrosomia, intrauterine fetal demise, neonatal hypoglycemia, and neonatal hyperbilirubinemia, among others. In addition, diabetes in pregnancy increases the risk of obesity and type 2 diabetes in the offspring later in life. Several studies have shown improved diabetes and pregnancy outcomes when care has been delivered from preconception through pregnancy by a multidisciplinary group focused on improved glycemic control. One study showed that care of pre-existing diabetes in clinics that include diabetes and obstetric specialists improved care. However, there is no consensus on the structure of multidisciplinary team care for pregnancy and diabetes, and there is a lack of evidence in the impact of outcomes of various methods of healthcare delivery. Recommendations for preconception care and counseling includes the following. 1. Starting at puberty and continuing in all women with reproductive potential. Preconception counseling should be incorporated into routine diabetes care. 2. Family planning should be discussed and effective contraceptions should be prescribed and used until a woman is prepared and ready to become pregnant. 3. Preconception counseling should address the importance of glycemic management as close to normal as is safely possible, ideally A1C of less than 6.5% or 48 millimoles per mole, to reduce the risk of congenital anomalies, preeclampsia, macrosomia, and other complications. 4. Women with pre-existing type 1 or type 2 diabetes who are planning pregnancy or have become pregnant should be counseled on the risk of development and or progression of diabetic retinopathy. Dilated eye examination should occur ideally before pregnancy or in the first trimester, and then patients should be monitored every trimester and for 1 year postpartum as indicated by the degree of retinopathy and as recommended by the eye care provider. 5. Women with pre-existing diabetes should ideally be managed in a multidisciplinary clinic including an endocrinologist, maternal fetal medicine specialist, dietitian, and diabetes educator when available. This ends our discussion on preconception care and counseling. See you next time when we discuss antepartum care.